So at this stage, we'd like to solicit questions from the audience.
Maria.
Thank you. Excellent presentation, Stefan. I have a question to you about surface antigen levels. You haven't shown results, but Admir have showed that there is no decline in HBs antigen levels. How do you explain there is no decline?
Yeah, that's of course a very interesting question. So because if you assume that the S antigen reflects directly the cccDNA amounts, you would expect an S antigen decline. And our hypothesis is that you get less cells infected that would then produce more S antigen per cell. So the key question on that is there really, does that really reflect S antigen level? Does this really reflect the replication efficacy, number of infected cell, number of cccDNA? What we see as well is when we take away the Mercredex and it rebounds the virus, we get sometimes 2 logs of virus going up, no change of S antigen, although we obviously infect more cells. I currently think that S antigen can be very, very tightly regulated in a chronically infected patient, independent of the number of infected cells to some extent. That might be produced by the X protein. We know that cccDNA can be shut down by 100-fold if you control the transcriptional regulation of cccDNA. So the current hypothesis, what we're looking at is, of course, how does S antigen in a normal resolvement of an infection declines? Does it just parallel the number of infected cells, or is it a critical value that you come to, and then you get a sudden decline and then maybe immune reactivation? So my answer is, of course, we would like to have biopsy material and looking at the number of infected cells, which of course we would like to do now in the oncoming trials. But I'm very critical in just thinking that the S antigen levels reflect the number of infected cells during the infection.
Stefan.
Another question to Dr. Urban. Can you absolutely exclude that in vivo there is no cell-to-cell spread of HBV via tight junction not involving the NTPC receptor?
It's a very, very important question also regarding both B and delta, because there are differences. So the good argument that we have for a very, very limited spread independent of NTCP from cell to cell in the liver is these chimeric mice, where you transplant human hepatocyte into a mouse, you infect those mice for 3 weeks, and then you have single cell infected from the initial infection. And then you give the entry inhibitor for the next 4 weeks or 8 weeks. And you keep those single cells infected, you freeze these kind of spreads, and then you take it away and then you see clusters coming up in those mice. That's a very good indication, at least in that mouse model, that their spread in HBV needs de novo infection of cells. And it's very important that that's my concern, obviously, for the delta. In delta, that's different. In delta, you can put delta in and let the cells divide, and you get delta replicating. Could even be that delta rescues itself by cell division as a genome and can wait there until it gets another envelope protein to spread further. So whether you can really eradicate delta with this infection efficacy can still be questioned, even if you can very nicely control it. But there's a difference, and I think it's very potent in HPV.
All right, we want to take more questions because there's more people, so short answers. Harry?
I actually had a short question to Stefan, which I think you already answered. You didn't see any S antigen decline after you stopped in patients with a flare, right? So it stayed flat?
Yes. Yeah, it stays flat. I was wondering about that. It's flat.
And you could not predict these flares in any way from ALT values, pre-treatment, whatever?
So in these patients, we did not look very carefully at the kinetics after removal at the thing. But one should look at that because it's yeah. I cannot tell you a correlation on ALT and.
Yeah. Well, one very short question here to Heiner, if you allow me. So you show that after treatment, there's roughly 25-30% sustained response in Delta, which we know for more than a decade already, but then there's also these late relapses. If you add it all up, or if you subtract it all, what is the eventual response rate to interferon hepatitis delta, and should we still use it in clinical practice?
Yeah, so the intent to treat analysis, if you would then start off with 100 patients and exclude also those where you may have contraindications, you may end up with 10% or so. But still, what we showed, even though we showed these late relapses, those patients with late relapses still had a good outcome. So none of them did develop a clinical event after 5 years. We also have evidence from France, from the Greece cohort, from the Italian studies that delta RNA negativity is associated with a better outcome. And if you can achieve a delta RNA suppression, at least transiently, I believe we're doing a good thing to patients. But we have to select patients carefully. Do not treat everyone, and BRB patients are, for me, the candidates.
Jeff?
Thanks, I agree. Those were excellent talks. I'd like to ask Amir, are we not setting our sights too high to eradicate HBsAg? We know that the virus will integrate. We've known for 30 years, for example, from the Alexander cell line, a tumor cell line which contains only integrated HBV DNA, that can still get HBsAg expression. So I wondered if really a more realistic sight is to not have an eradication of HBsAg, clearing the last cell from both integrate and episomal hepatitis B DNA probably seems very difficult, but we could aim for functional cures where we get transcription of HBsAg and cell replication down to such a low level that it becomes a benign disease. I just wondered whether, as we design clinical trials, what we're really aiming for, because clearance of HBsAg is going to be very difficult because all patients will have integrated viral genomes which will continue to express HBsAg. But we may more realistically get to a functional cure, HBsAg positivity at very low levels of replication, implication, and inflammation, and it becomes a benign disease off treatment.
I agree. I'm not so concerned about the integrated form because, as we know, the integrated forms cannot really make functional viruses. But the point is that even with the best DNA suppressors, the entecavir and tenofovir, recent studies show that you do not really eliminate the chances for HCC, for example, and other problems as well. And you cannot really know what a foreign CCC DNA is doing there in the liver in terms of oncogenesis and other problems. And of course, we have the problems of many patients who are getting treated with immunosuppressive drugs now and the danger of HBV reactivation and so on. But I do agree that I think that we should aim for as much as CCC DNA clearance as possible, and this will probably come from immune control, from better immune control in a non-cytopathic way. So ways to somehow getting rid of the CCC DNA, to find those ways should be, I think, the answer.
Okay.
Okay, well, thank you very much. I would like, again, we heard 3 really outstanding talks in this session.